Okay, guys, so hello to anyone who has recently joined. Uh, so, this is our last exercise, and because last week we missed the exercise about therapeutic drug monitoring, or TDM, we are going to do this today, and plus we're going to talk about immunosuppressive drugs, and also uh, about drugs used in pregnancy and in lactation shortly. This was supposed to be part of exercise 11, but I decided to do this as part of the last exercise because it's a short topic and I think it's an important one. Okay, so let's start. Also, I'll be recording this exercise for anyone who would like to listen to it later. Okay, so today's first topic is about therapeutic drug monitoring, also called TDM. Although it sounds a little bit complicated, it basically means measuring the drug's concentration in the patient's blood or plasma in order to determine the best possible dosage for this given patient. Also, we're going to talk about the capabilities and limitations of the current methods of conducting optimized and individualized pharmacotherapy, which is also part of TDM and is closely related to TDM. Then we're going to talk about pediatric pharmacotherapy, and then pharmacotherapy in pregnant and lactating women. So let's start with therapeutic drug monitoring. So we said that this is basically giving the patient a drug, and then after a specific time period, let's say 2 hours or 4 hours or 12 hours, it depends on your decision and on drug's pharmacokinetic profile. You take a blood sample and you measure the concentration of the drug in the blood sample. Why do we do this? Why do we monitor plasma or blood drug concentrations? First of all, to avert toxicity, to optimize those therapeutic response, to detect changes in pharmacokinetics, and to monitor compliance. So if you have a patient and you prescribe this patient, let's say, carbamazepine, which is a drug that is used in epilepsy, but this patient is still having epileptic seizures, and you want to find out why this patient is still having epileptic seizures. You can measure the carbamazepine's drug concentration in order to see whether the patient has been taking the drug or not. Also, there are some cases when the patient is taking the drug, but it is not the right dose. So you need to either increase the dose or decrease the dose. So these are some of the reasons why we monitor the drug's concentrations in the blood or in the plasma of the patient. Another very important topic is about the therapeutic index of the drug. And what we mean by therapeutic index, it's actually a very basic concept in basic pharmacology. Maybe you remember therapeutic index from third year pharmacology. For those of you who don't remember, this is actually an index which does not have measurement units, because it's just an index, and it is calculated by dividing the toxic dose in 50% of the individuals by the effective dose in 50% of the individuals. So let's say when we're talking about NSAIDs, and acetylsalicylic acid is actually an NSAID, in order to get to the toxic range, usually of acetylsalicylic acid, or aspirin, which is the trade name of acetylsalicylic acid, or ASA, we need to have around 10 grams, which is 10,000 milligrams. So this is the toxic dose when around 50% of all the individuals who were given this drug gets toxic effects. Let's say we did a study with 100 patients, and 50 of them, when they were given 10 grams of ASA, got some toxic effects. This means this is the TD50, or toxic dose in 50% of the individuals. And this we divide by the effective dose in 50% of the individuals, which is called the ED50. And let's say this is around 100 milligrams. So 10,000 milligrams divided by 100 milligrams, this is equal to 100. So in this case, the therapeutic index of acetylsalicylic acid is 100. Tylenol, which is the trade name of paracetamol, and by the way, paracetamol is not an NSAID, so this table is not completely correct, but I keep this as an example so that you remember that there is a mistake, that Tylenol, which is paracetamol, is not an NSAID. Actually, is not a drug with a very high therapeutic index, because in order to get to the toxic doses of paracetamol, you only need to take 6 or 7 drugs of paracetamol, let's say tablets. One tablet is usually 500 milligrams of paracetamol. So if you take, let's say, 6 or 7 tablets per 24 hours, there is a risk of getting hepatotoxicity, which means let's say 6 tablets, 6 times 500 is 3,000 milligrams, or 3 grams of paracetamol divided by 500, which is, let's say, the effective dose. This is only 6. So the therapeutic index of paracetamol is 6, and of ASA is 100. And this is so with also other drugs like lithium, some neuroleptics like phenytoin or phenobarbital, which have a very low therapeutic index. So low therapeutic index means that these drugs have a very high potential of causing toxic effects with very small increases in dose. So these are the drugs that we need to monitor very closely, because let's say you can take 5 tablets of ibuprofen and probably you won't get any toxic effects. But if you take 5 tablets of digoxin, there is probably going to be some toxicity like arrhythmia, which can be deadly, ECG changes, vision changes like yellow, greenish discoloration, or other unwanted toxic effects of the drug. So we have high therapeutic index drugs and we have low therapeutic index drugs. For most part, for the high therapeutic index drugs, we don't need monitoring because we consider them relatively safe, even at higher doses than usual. But for low therapeutic index drugs, we need to sometimes do TDM or therapeutic drug monitoring by measuring their concentrations like gentamicin, vancomycin, amikacin, digoxin, lithium, some immunosuppressives like tacrolimus or cyclosporin. So these are some examples for drugs that need therapeutic drug monitoring. Which drugs do not need TDM? So for most drugs that have a surrogate endpoint that can be easily monitored, and if you remember from our first exercise this semester, we talked about clinical and surrogate endpoints, and let's say a clinical, which is the real endpoint that we care about, like decreasing death, decreasing myocardial infarction, decreasing stroke. These are the things we actually care about, but we use some surrogate markers or surrogate endpoints to measure their effectiveness, the effectiveness of the therapy that we prescribe. We use surrogate endpoints. So for, let's say, for if, our example was for blood pressure, we said that we need to treat blood pressure, not because we really care that much about the blood pressure itself, but we care about the rate of myocardial infarction and the rate of stroke and the rate of other complications that can cause our patient to die, which are our clinical endpoints. We use the blood pressure only to measure how effective our treatment is. So that's why we call this surrogate endpoint. And for most drugs that are used to treat diseases with a measurable surrogate endpoint, like heart rate, cardiac rhythm, blood pressure, blood sugar, blood cholesterol, and triglycerides, we don't need therapeutic drug monitoring, which means most antihypertensive drugs, most diabetic drugs, they do not need monitoring because it's really expensive and it's hard because it needs patient cooperation. We need to know when exactly the patient took his or her last dose of the drug, and we need to also write down the exact time when we take the patient's blood. And this is really, as I said again, an expensive and complicated procedure to do TDM. For these drugs, we only need to measure the blood pressure or the blood sugar to know that we are effective, and this can also show us in what direction we need to change the dose of the drug. That's why these are called surrogate endpoints. For drugs that serum concentrations do not correlate with therapeutic or toxic effects, drugs with less complicated pharmacokinetics, drugs that are used to treat less complicated or not life-threatening diseases, we also usually do not need therapeutic drug monitoring. What are the drugs that need therapeutic drug monitoring? Well, some examples are theophylline, which is a bronchodilator used in asthma, COPD, and other pulmonary diseases. Some antibiotics like aminoglycosides like gentamicin, other antibiotics like vancomycin, immunosuppressive drugs like cyclosporin, tacrolimus, anti-cancer drugs like methotrexate, they need therapeutic drug monitoring. Besides them, the commonly used antiepileptics like phenobarbital, phenytoin, carbamazepine, valproate, or valproic acid, digoxin, lidocaine, sometimes when lidocaine is used as an anti-arrhythmic drug. As you know, lidocaine is mostly used as a local anesthetic, but it can also be used intravenously as an anti-arrhythmic drug. Then we sometimes use therapeutic drug monitoring to measure the plasma drug concentration. Another important term when talking about therapeutic drug monitoring is the volume of distribution, or the VD, which is not a real volume of liquid in a patient's body. And this is actually the amount of blood which can be given per kilogram of body weight for the patient, necessary to contain all of the body burden of drug at equilibrium concentration. So this may seem as a very complicated definition, but it is not really that complicated, and I'm going to show you why in a minute. And in this case, the plasma concentration is equal to the total body stores of the drug divided by the volume of distribution. And we have drugs with a low volume of distribution and drugs with a high volume of distribution. And the drugs that have a low volume of distribution, this actually tells you that these drugs are distributed not that much in the tissues, but mostly within the intravascular space. So some examples are the aminoglycoside antibiotics like amikacin, gentamicin, tobramycin, some antiepileptic drugs like phenytoin, valproic acid, but also theophylline and ethanol, which is also a molecule or a drug with a low volume of distribution. And then we have drugs with a very high volume of distribution, like digoxin, carbamazepine, propranolol, and these are liters per kilogram. So if you have a patient with 70 kilograms and you like to calculate the volume of distribution of quinidine, let's say in this patient, you multiply 70 by 3, and this is 210 liters volume of distribution of quinidine in this given patient. So mostly these drugs like to distribute not in the intravascular space, but mostly in the tissues, like in muscles, in fat. So this gives you idea of where the drugs concentrations are highest and where the drugs stores are mostly located, the volume of distribution. Criteria for TDM. The assay methods are very important in TDM, and we also need to have a very good relationship between the serum drug concentration and the therapeutic or toxic effect, which means that if we are going to do TDM, we should expect that the drug, when its concentration is very high, it's going to have toxic effects. When it's very low, it's going to have no effect at all, or very small effect. And when it's in the middle, it's going to have a therapeutic effect. If we don't have a relationship between the drug's concentration and the therapeutic or toxic effect, then there is no reason to do TDM, because we cannot assess our therapeutic options of how to change the drug's dosage based on the drug's concentration and the drug's effectiveness, because they are not related. Okay. What are some assay methodologies to do therapeutic drug monitoring? We have different enzymatic methods like EMET, ELISA, which I think you should have seen so far. maybe in your microbiology classes or chemistry or biochemistry classes. ELISA is one of the most commonly used methods of, and this means enzyme-linked immunosorbent assay. This is highly automated. There are some machines that do this almost automatically. You don't need to do anything besides just getting the samples of plasma or blood, and it has relatively quick turnaround, but it is not very sensitive. It is of moderate sensitivity, so it is not one of the most sensitive methods, unlike the RIA, which is a radioimmunoassay method, which has a high sensitivity, but it has a long turnaround. It can have many interferences, and also it includes radiation. But there are two other methods, which is the FPIA, the fluorescence polarization immunoassay, and the HPLC, which is high performance liquid chromatography. And I think you have probably seen HPLC also. And HPLC actually is one of the most sensitive methods. There are many assays available, which means you can measure a lot of different drug concentrations. It is not expensive as compared to the other methods. It has a long turnaround, which is the negative side, but it is really, really sensitive, and some hospitals do have it. Some of the assays measure the total drug concentration. Some of them measure the free drug concentration. And what do we mean by free drug concentration? You know that some drugs are bound to proteins, and some drugs have also free molecules, and depends on which kind of assay you are going to choose, but mostly the effective concentration of the drug is measured. If the metabolites of the drug are also of some therapeutic value, like they have some activity, then we can also measure the metabolites concentrations. Appropriate use of TDM is related to maximizing and speeding up efficacy, minimizing toxicity. So these are our goals when doing therapeutic drug monitoring. When there is a poor response to the initial therapy or deterioration after initial good response, when the hepatic or renal functions are changing, because this is important for drugs elimination and drugs pharmacokinetics. So sometimes we need to change the dose according to the liver or renal function. And also when we have drug interactions or drug food interactions, we need to do therapeutic drug monitoring. Some factors that can affect serum drug concentration, of course, renal, liver disease, very important, but also cardiac and thyroid disease, pregnancy, non-compliance, electrolyte imbalances, these are important. So, maximizing efficacy, we talked about this, and avoiding toxicity, these are the two main reasons why we do therapeutic drug monitoring. Identifying therapeutic failure also is another reason why we do TDM when there is especially non-compliance. This is how you actually calculate the new dose of the drug when you multiply the old dose by the desired steady state concentration divided by the old steady state concentration. So this is once you get the information about the concentration of the drug now and the concentration that you desire to get in the future. This is actually how you calculate it. Okay. Cost benefits of TDM. Yes, there are some cost benefits. Of course, this is very important nowadays because everything needs to be cost effective. We don't get money from the governments, and the hospitals don't get money from the governments to spend the money however we like. This is not the case, maybe, unfortunately, we can say. That's why we need to have a very good understanding of when we need to spend the resources that we are given, because if we spend our resources without thinking, then we won't have enough resources to spend on patients that really need some therapy or really need therapeutic drug monitoring, which we said is a relatively expensive test. But TDM has been shown to reduce some hospital congestion to some extent, increase the quality of therapy and service, and also it promotes research and science. There is also a medical legal aspect, like when we're talking about alcohol, of course. And again, we need to consider when we really need therapeutic drug monitoring and when we don't need therapeutic drug monitoring. Okay. What are the problems of therapeutic drug monitoring? Well, there is, of course, the problem with not knowing that therapeutic drug monitoring exists. This is a big concern because sometimes it can really help to know what is the concentration of the drug in a given patient in order to determine, let's say, when you are observing a specific toxicity, if this toxicity is related to the drug or to something else. So it's always good to know that therapeutic drug monitoring exists. But sometimes the physicians that use therapeutic drug monitoring, they don't know how to correctly use the information from the patient. And this is an example of a form of therapeutic drug monitoring, which needs to be filled usually by the physician. So you write the patient's name, age, and other information, drugs or the drug that you want to be assessed, the reason for your request. Do you suspect some toxicity? Do you want to assess compliance? Do you want to just confirm the therapeutic effect of the drug? When do you need the result? Stat means statin, or immediately, within 24 hours, or within 1 to 2 hours. And this is very important. Time and date of last dose. When the drug was exactly taken, and I mean to the minute. Was it taken at 8:05? Was it taken at 7:31 or 7:39 maybe? Was it given intravenously, subcutaneously, or in some other way? And when the sample was taken, so sampling time, date and time exactly. So when the nurse or you or some other person took the sample from the patient, when was the blood taken? And again, here we need this information exactly to the minutes. Does the patient have any organ system damage, like renal, hepatic insufficiency? And this is how a form looks like. These are some examples of the therapeutic range of drugs like aminoglycosides, um, antineoplastics, immunosuppressive drugs like cyclosporin, the dose and when we need to measure the concentration, etc. Uh, Here again, some other drugs like lidocaine, digoxin, theophylline also, and you know that theophylline actually has very different pharmacokinetics depending on the patient's age and whether the patient is a smoker. So it has a different half-life in children, in infants, in newborns, in adults, in preemies, and also in smokers. It has a different half-life, and this is sometimes a question that's asked in the exam. Also, acetylsalicylic acid, nortriptyline, lithium, which we said is a drug with a low therapeutic index, so a drug with a high potential of toxicity. The second part of the exercise we said is about pediatric pharmacotherapy, which is also related to therapeutic drug monitoring, because in children we have very different pharmacokinetics because the organ systems, especially during the first couple of weeks or months in the life of our patients, metabolic changes are um, happening. The organ systems are still maturing, so sometimes we really need to closely monitor um, the drug concentrations. Um, Again, the pharmacotherapy in pediatric patients is usually concerned with the safe and effective management of drug administration by maximizing the drug's effectiveness and minimizing the drug's toxicity when it's possible. In children, there is a problem with the drugs uh, that 75% of the prescription we have indication most of the time because of several reasons. The main reason is that it's very hard to conduct clinical trials in children. And as you know, we need clinical trials in order to get approval for a drug to be used in a specific population. And for children, it's very hard for obvious reasons. And this is one of the main reasons why most drugs are off-label. Off-label does not mean incorrectly. It just means that there is no official approval by the FDA, EMA, or the national agency for this drug to be used safely in children. The drug's disposition in children is very variable, and as you know, this term is familiar from the first exercises. Again, we talked about intra and inter-individual variability, and in children, this variability is very, very high. Sometimes in children, we use scaling for calculating the dose that should be used in the pediatric patient based on data from adult patients, which is not so easy as getting, let's say, in an adult, you use 100 milligrams per kilogram dose, which means in an adult who is 100 kilograms, we have 100 times 100, which is 10,000 milligrams. Um, and if you have a child who's only 10 kilograms, like around 1 year of age, then 100 times 10 is 1,000. This is Again, an example of scaling, but this scaling is very simple, and it is usually not the case for most drugs. So it is not as simple as going from a milligram per kilogram from adults to children, because children usually have a faster metabolism and they usually require not lower but higher milligram per kilogram dose as compared to adults. What are the differences in absorption of drugs in children, in neonates, and in infants? As you see, the gastric pH in neonates is over 5. In infants, it decreases to 4 to 2. In children, it is usually at adult levels. So this can affect drugs that are acidic, or they require an acidic environment to be absorbed when, let's say, you are using this drug in neonate patients. Okay, also the percentage of extracellular water in premature children and in newborns, it's very high, and especially in the premature. With age, this extracellular water decreases, and you can see here percentage of total body weight for fat, protein, intracellular and extracellular water. And in adults, and especially in the geriatric population, you know that extracellular water is very low. The fat is also higher, and protein and muscle mass is actually lower in the geriatric population. As you remember, we had a separate exercise for geriatric pharmacotherapy. So these are the changes that happen with increasing age, and this can also affect the distribution of drugs. So it can affect the volume of distribution, or VD. Metabolism is also different in children, especially newborns are at a very high risk for concentration-dependent toxicity, which means as the concentration gets higher, the risk of toxicity also increases due to developmentally delayed drug metabolism. For example, chloramphenicol, which is an antibiotic, and it can cause severe toxicity in newborns and in small children. This is the liver mass to body weight ratio with age. As you can see here, is the newborn, then the liver mass to body weight actually increases. So as a percentage, it gets to around 4 or even more than 4.2 or 3% of body weight for the liver, and then it decreases with age. And this also means that here we're going to have different concentrations and different first pass metabolism in patients. If you look at this plot with different ages. For immunosuppressive drugs, which are used also in this population of pediatric patients, especially after liver transplantation. And you know that patients with a biliary cirrhosis due to absence of biliary ducts, they get end-stage liver failure and they require liver transplantation. So this is also a topic that is related to the pediatric pharmacotherapy and also to therapeutic drug monitoring, because most immunosuppressive drugs require therapeutic drug monitoring. What are some immunosuppressive drugs that are used in organ transplantations? We have corticosteroids, of course. Then we have small molecule drugs like immunophilin binding drugs. These are the game changer drugs, if I may call them so, in transplantation. And we have these drugs for the last 30 to 35 years, and they really make a huge difference in the treatment of organ transplantation patients, and they prolong the life of these patients by providing immunosuppression and survival of the transplant graft. The calcineurin inhibitors, which are the cyclophilin binding drugs like cyclosporin and the FKBP12 binding drugs like tacrolimus, they are really, really important. But we also have target of rapamycin inhibitors or mTOR inhibitors like sirolimus and everolimus, which, by the way, are also drugs that prevent neoproliferation and restenosis in patients who get stented, especially intracoronary stents. If you have seen this abbreviation DES or DES, DES, this means drug-eluting stent. So a stent that elutes or releases drug. These drugs are usually mTOR inhibitors like sirolimus or everolimus. And the idea is that when the stent is put into the vessel of the patient, usually a coronary vessel, with time, the stent is releasing slowly a drug like sirolimus, which is an immunosuppressive drug, but it also prevents restenosis, so that the vessel doesn't close off. So this is another indication for using the mTOR inhibitors. Then we have inhibitors of nucleotide synthesis, the purine synthesis inhibitors of mycophenolate mofetil, which is a very, very commonly used drug again in transplant recipients, usually liver transplants. Also, we have some pyrimidine synthesis inhibitors like leflunomide. And then we have the anti-metabolites like azathioprine or methotrexate. Let's talk about a little bit about cyclosporin. This is a drug with a trade name of Neoral, but it also has other different trade names, and it is one of the first immunosuppressive drugs of its class, and its mechanism of action is through binding to cyclophilin, which forms a complex that inhibits the calcineurin phosphatase, and this leads to less T cell activation. And T cells are involved in the immune reaction against the transplant grafts. So when less T cells are activated, this means the organ is not rejected. Tacrolimus is the newer drug of the cyclosporin class. So first drug is cyclosporin, and then we have tacrolimus. And tacrolimus actually replaced cyclosporin in liver and in kidney transplantation because it has relatively less adverse drug reactions as compared to cyclosporin. So this is very important. That's why tacrolimus is nowadays the first-line therapy for liver and kidney transplants. And adverse drug reactions are similar to cyclosporin, but they are less. So this we need to really underline. And adverse reactions can include hypertension, hyperlipidemia, skin changes, hirsutism, gum hyperplasia, nephro and neurotoxicity. And because it's also an immunosuppressive drug, of course, it is related to the immune system, and there may be more lymphomas and more tumors as a whole because they decrease the immune system, and some cancer cells can escape the immune system and cause cancer in patients who are getting immunosuppressive drugs in the long term. Sirolimus and everolimus, we said, are rapamycin inhibitors, and they bind to a different protein than cyclosporin, but the effect is the same: less T cell proliferation, less T cell activation, so less immune reaction. So thank you for your attention. Now we'll continue with the second part of the exercise, which is even shorter. So if you have a few more minutes, we'll finish quickly. Let me open the presentation. Okay, so drugs used during pregnancy and lactation. Pregnancy, what is different? So a lot of different changes occur during pregnancy. I am sure that you know in detail about these changes from your obstetrics lectures and exercises. So this is an important topic also in clinical pharmacology, and we need to just go over the changes that can affect the pharmacokinetics of drugs during pregnancy. If we have to talk about absorption, actually not a lot of changes that are really important happen. So gastrointestinal motility, for example, is decreased in pregnancy, but this appears to be of no major effect in drug absorption, except that reduced gastric emptying delays the appearance in the plasma of orally administered drugs, especially during labor. So this means that probably when we give the patient a drug that is usually absorbed in the gut, the effect of the drug is going to happen later than expected because of the slow gastric motility. Absorption from an intramuscular site, so when you administer a drug intramuscularly, is likely to be efficient and even sometimes more efficient because tissue perfusion is increased due to vasodilation during pregnancy. When we talk about distribution of drugs during pregnancy, as you know, total body water increases up to 8 liters in pregnancy, and as a result of this we get hemodilution and also a relative decline in hemoglobin. Why this is relative? Actually, the amount of hemoglobin increases, but because the amount of water increases by even more, we have a relative decline in the concentration of, let's say, from 120 to 140 to around 100 milligrams per deciliter, or 10 grams per liter. So it depends which units you use. Hepatic and also renal metabolism increases, and this affects the drugs that are metabolized by the liver and by the kidneys, so they are usually eliminated faster than usual. Because renal plasma flow also increases. What about the placental transfer of drugs? Well, the placenta is not a perfect barrier to drugs and chemicals, and it usually does not stop all drugs that are administered to the pregnant woman. And an example here is, of course, the classic example with thalidomide, which was a great tragedy more than 50 years ago, which involved this drug thalidomide, which was given for nervousness, restlessness, and sleeping disorders, and also nausea in pregnant women. And it was thought to be relatively safe. So a lot of patients received this drug during the 50s, 60s. But because of this drug, mm, and because of the fact that no one expected teratogenic effects, it was a tragedy because a lot of children were born with different malformations, usually involving the upper and lower extremities. And that's why you need to be very careful when prescribing drugs to pregnant women. You need to have a really good indication, and you need to know that this drug is safe and can be used in pregnant women without any effects that can involve the fetus. Here is the here is this figure where you see that small molecular weight drugs can pass more easily through the membranes by passive diffusion, but larger molecular weight drugs cannot do this. Um, you know what a teratogen is already, so this is an example of what thalidomide caused during the 50s, 60s, and 70s. Focomelia is the malformation, the teratogenic effect of thalidomide. There are, of course, other drugs that can cause this, like also ACE inhibitors and ARBs. For these drugs, we know that they're teratogenic, so they must not be used during pregnancy. These are some morphologic abnormalities that can happen during the embryonic period due to some drugs. And this is actually another very important table that can get asked in the exam about the different categories of drugs, which are from A, B, C, D, and X, depending on the risk of getting malformation. So for drugs that are category A, there are adequate studies in pregnant women that have failed to demonstrate a risk to the fetus. So they are safe drugs. For drugs X, there are enough data to show that they're very high risk to cause malformations, and they should not be used during pregnancy. Okay, so one more important table, and here is another table that is also important, and also you can get some questions in the exam of the different drugs and their related abnormalities that can cause can happen during pregnancy, like carbamazepine, neural tube defects, alcohol, low IQ baby, growth retardation, fetal alcohol syndrome, ACE inhibitors can cause hypoplasia of organs, growth retardation. Antithyroid drugs can cause fetal goiter and hypothyroidism, and so on. Again, prescribing in pregnancy should be a balance between the risk of adverse drug effects on the fetus and the risk of leaving maternal disease untreated. So this balance should be kept, and you should really be careful. You can always check drug information, whether if it's safe in pregnancy, but ask yourself first the question, does the patient really need this drug? Is it something life-threatening? Do you have any good indications to give this drug? Because every drug carries a risk of causing toxicity to the mother and also to the fetus. That's why we need to minimize prescribing when possible. Of course, sometimes you must use drugs, but you must choose the safest drugs. Drugs used during lactation. Most drugs that are administered to lactating women are actually detectable in breast milk, but most of these drugs are usually at a very low concentration to cause any effect to the fetus, but in order to minimize this effect, these drugs should be given 30 to 60 minutes after nursing or 3 to 4 hours before nursing. But some drugs like sedative or hypnotic drugs, lithium and tetracyclines should not be given to lactating women because, as you know, they're of potentially high toxicity, especially tetracyclines. You know, these antibiotics can cause teeth discoloration, bone abnormalities in children, and they are not given to even children, but also to pregnant and lactating women. So thank you for your attention. This was it for today. I am open to any questions if you have questions. Again, this was our last exercise. Your exam will be in 3 weeks time, right? 24th of February and 25th of February. So the first 4 groups on the 24th and the second 4 groups on the 25th. Your exam is going to be a multiple choice question test, and it will probably take around 40 minutes, and the results you are going to get probably 2 to 3 hours after the exam. Also, if you decide to use the presentations from the exercises, you can do so. I'm going to send you the presentations from the second part of the semester, so the last couple of presentations in the coming days. And also, you can use the textbook, the blue textbook, some other textbooks, and also the presentations from the lectures, of course. It was a pleasure for me to have you this semester. We started by doing live exercises. Unfortunately, we finished them online. I hope that you are going to remember some practical things from these exercises, even though they were online. And yeah, I'm always open to questions, or if you think that I can help you in any other way, you can always find me. You have my contacts, and you know that I am at cardiology at our hospital. So yeah, thank you. Thank you too. I don't see any questions, so I wish you guys good evening. And good luck in the exam. Stay safe, and we're probably going to see us during the exam. I hope I'll be there. So see you guys then. Bye bye.